The speaker's introduction. Dr. Suhail Chughtai, FRCS, orthopedic surgeon based in London with over 20 years of consultant-level experience in the UK, Pakistan and Saudi Arabia. Microsoft certified specialist and fellowship holder in clinical telemedicine with over 15 years of experience as a telehealth innovator and strategist. Designer of telemedicine software for over 20 international telehealth projects in various countries. Chief Technology Officer of the Health Bank Global.
Clinical telemedicine is bringing a true healthcare revolution in Pakistan. Allow me to share some of the thoughts on that particular one, and whatever I'm going to share today will be representing the direct work I have been involved in Pakistan by designing telemedicine software and by implementing the solutions in the real scenario. So telemedicine, the clinical telemedicine means that doctor and patient are meeting over telecommunication assisted by a clinical decision support system. It's not just audio-visual communication. The clinical decision support system is part of the clinical telemedicine setup. So in that scenario, we have direct telemedicine when doctor and patient meet on a website or through an app without assistance of any mediator or clinical assistant. An example for that we implemented in Pakistan is this particular project, which was the telemedicine 24/7 helpline, which has seen a large number of patients, around 1 million patients put through, who were given a chance to see a doctor directly without the help of any assistant on the telemedicine software. And I designed this with a view to minimize the learning curve both at the doctor and the patient side, as this was put up in a fairly short space of time to reduce the load of patients going to hospitals and clinics in Pakistan. And that project is still running. Then there is assisted telemedicine, or a hub and spoke type, where there is a fixed spoke. That's the point where the patient would come in and be assisted by a clinical telemedicine assistant or a coordinator who will connect the patient to a doctor through a laptop or a tablet available at that particular spoke. Now, this spoke can be fixed like a basic health unit in Pakistan, like in villages where there are junior doctors, primary care physicians, or at times a nurse or a dispenser only. And then the mobile spokes where a motorbike rider can reach the patient at home who cannot see or cannot visit the basic health unit. Now, this particular project was implemented by, again, at a large scale in Pakistan. And I designed this project. In Urdu, we call it Sehat Ghar, or the House of Health. The idea was to connect the basic health unit with a specialist in a teaching hospital or a district hospital, so the patient does not have to travel. Now, these Urdu names, they are translations of clinical psychologist. Like here we got speech therapist, we got cardiologist. So these were the specialists who were logged in at district hospital, and they were taking appointments from patients on telemedicine who visited basic health unit where there was no specialist. And this was by appointment, whereas the project you've seen previously, the doctor was available online 24/7. So the difference between the two is that here you got an appointment to make, whereas in the project before, the doctor was available online 24/7. So then we have hybrid model, where you have both online appointments, instantly available physician, or by appointment, and that's hybrid model. In that case, this was a project we implemented in the private sector, and this project enabled physicians to offload the rush of patients to clinics, to private hospitals, so that doctors are safe, the patients are safe, and there is less traffic and transmission of the disease in the COVID, first phase of COVID in Pakistan. So there are other types of telemedicine we implemented in Pakistan. For example, the general outpatient telemedicine, where complaints which are other than corona, they were dealt during through the telemedicine helpline. Then we had specialist telemedicine services like telecardiology, telepsychiatry. Especially telepsychiatry needs a mention because a lot of mental issues, mental health issues were brought to the surface during the COVID first and second phase. Then we have integrated telehealth hospital system. That is an advanced model of telemedicine system where the hospital information management system is incorporated within, which includes the billing, the inventory, and similar other processes. Then ambulances, we have been working to set up a pilot in Pakistani emergency rescue service 1122. They have ambulances all over the country, and at present we are in the process of setting up a tablet-based patient triage in transit. Telemedicine in a box, that project is nearly being finalized for the soldiers, where we are going to provide telemedicine boxes to the frontline warriors. Telesupervision of surgical procedures, that is again a software which is designed to help the smaller town hospitals surgeons be supervised by senior surgeons who are not available to visit the small hospital, but they can still supervise the procedure through this particular software designed for the service. Then we have telepathology and teleradiology. Basically, they are the collection points where the radiologist and pathologist are sitting far away from the service, from the collection point, but is instantly available through the telemedicine service to make a report. So further types of telemedicine, which are basically, we're touching on advanced telemedicine systems where single channel is where only webcam and audio is available, whereas the multiple channels where you have multiple video cameras or multiple inputs, like you can attach an ENT camera along with a webcam. You can attach a dental camera while keeping the webcam on. And then you have other elements of multi-channel telemedicine where normally is one doctor, one patient system that's called single channel telemedicine system, whereas multiple channels are where the doctors can be multiple, like a board with one patient, or there is one doctor but multiple attendants like patient and the relatives. They could be in different countries. And this means that a board formation can be done in a teleconsultation. An electronic medical record sharing system again can be either through a live screen sharing using an iframe, which is shared by both patient and doctor, or it can be API-based push and pull system of the records. So the service delivery types of telemedicine, like workplace telemedicine in schools, army deployments, charity camps, ship or air journey, public mass public sports, kiosks. That thing is some of the elements are being deployed in Pakistan, but in general, it is not a very wide concept available at present in Pakistan. Now, the technology has evolved in Pakistan from the voice-only telephone calls to video calls without data, like video chat public software, video conferencing platforms like Skype, Zoom, and from that, we stepped into the clinical telemedicine where you have a live video window overlapped by electronic medical records, but not within the same software. So there is a drawback for that. For example, if the live video service shuts down or the country doesn't allow that, then you cannot do a telemedicine in that particular setup. So this is which I call a non-clinical telemedicine, or the initial stage of telemedicine systems. But now what we are doing in Pakistan is this particular aspect where the live two-way video is integrated at the code level within electronic medical record system. The benefit of that is actually not one, there are many benefits of that, but that is beyond the context of this discussion. Briefly, I touched that they work integratedly, they have complete data security, and then there is HIPAA compliance and other GDPR compliances can be met very easily. The software is one, so it's easy loading and easy integration between all the elements of the software. Now, this live two-way teleconsultation can be integrated within hospital information management system, which is one step above the telemedicine system. Or they can be specialized audio and video channels integrated within a telemedicine system, like attaching a mobile scanner, like attaching an auscultation device, and all this can be advanced telemedicine systems. So the clinical telemedicine would would be qualified if you have integration between the EMR, information management system, and the video transmission. If they are dissociated, there would be problems eventually, and the data security can be compromised. And the clinical telemedicine basically is where there is one code for the whole system rather than multiple codes put together. So clinical telemedicine entails so many parameters like patient registration, appointment management system, electronic medical record management system, which text-based, images, sound, and video, live two-way teleconsultation, which is again a part of the telemedicine systems, clinical data collection system of a highly detailed type. And then you have clinical decision support system, like you have certain forms. If the patient has knee pain, the knee pain form pops up. If the patient has chest pain, the chest pain form shows on the surface, so a doctor follows a sequence. There's a prescription management system, interspecialty referrals, disease screening and research tools, clinical audit and governance system, and patient education portal. So all these, the elements I just mentioned, they qualify, they make the clinical telemedicine system rather than just a video conferencing tool, which is, I would say this is an outdated pattern, and people now should step into the clinical telemedicine systems. So now, as you see here, this is a demo of a software where a doctor is in the corner. That's the doctor screen. So the patient screen is bigger, the patient image is bigger, and doctor has certain tools on the left-hand side and some tools on the right-hand side to interact with the patient. That's a clinical telemedicine software system, which we designed for Pakistan, different telemedicine requirement systems. Now, in this case, you see that here we got a form coming up, which is a Corona's evaluation score form. That is what we use in Pakistan to segregate the disease burden into different categories. Then patient was able to upload the reports, and the doctor and patient can comment and see together. Same way, patient could take a picture through mobile phone of the X-ray and upload through the same system, and record certain visual findings which doctor can compare later. And doctor can also record the vital parameters and then examine on a video-to-video consultation within that software, and then make brief notes, write initial diagnosis, request further tests, which can be directly sent to the path lab, and also make a prescription, which can again go to pharmacy directly from the doctor's portal. The patient education system was a very important part of this particular drive, especially in phase 1. We had to train patients on hand washing and avoiding touching surfaces and following the protocols. So here is a doctor explaining on a YouTube video during a consultation. A doctor can show a clip of anybody on YouTube to demonstrate a technique, or can show pictures and then can send these pictures to the patient if the patient requests so. And this story was taken up by Pakistan has been taken as one of those 7 countries which fought COVID very well. And one of the reasons why we did so, apart from other policies of the government, was a timely deployment of telemedicine. So we were encouraged to write a book by a British publisher, and I involved my senior colleague, Professor Angus Wallace, to join me in this venture. And we did the book together, which was forwarded by Professor J. Saunders, who is the founder of American Telemedicine Association. He's my mentor, and I've taken his advice at time to time in different sectors. So he wrote a forward of the book. And this story is actually the narrative of Pakistan's telemedicine success. Like, it started on 12th of March when I was invited to a press conference in medical conference. That was the day when the lockdown was announced. And I suggested telemedicine to be used as a tool to fight the COVID onslaught, like limiting patient movement to the hospital. This was taken up by the governor, who met the vice chancellor, and they decided to implement that idea. And then everything was hurried up telemedicine centers were set up, starting from the University of Health Sciences initially, and then it spread to many other universities. It was inaugurated by the governor of Punjab, and that is where all the major departments and the political will of the government got involved, along with academic drive from the Vice Chancellor, Professor Dr. Javed Akram. And the governor got involved directly with all the modalities, all the higher level officials from different departments joining in the program. And then this went on, and then eventually it moved further. It was advertised on the national scale. Doctors were trained. I got involved in training from UK, and I was giving online training using local coordinators. Governor Punjab, Chaudhry Mohammad Sarwar, traveled with my team in different places to have it implemented in different universities. And then the training went on in different universities. And this was a national phenomenon. It was taken up very successfully by 5 medical universities and 17 medical institutions altogether, where we created telemedicine hubs. And we had an opportunity to examine more than 1 million patients. And I'll show you the data in a moment. Even the BBC took a notice, and they published a report on the success of telemedicine in Pakistan. The whole project was judged by international educators. Here's Professor Angus Wallace taking a look at the program, and then the different experts involved. They looked at the evaluation of the value of the project. Then we gave a briefing to the President of Pakistan, who came to University of Health Sciences a month after the telemedicine helpline was installed. He was very happy with the results, and this briefing eventually encouraged us further to develop telemedicine beyond the confines of one province and go into other provinces as well of Pakistan. So this is a story of success where a large number of doctors got involved. More than 500 doctors got involved, who were able to review the patients in excess of 1 million. And this telemedicine software was backed up by a telephone helpline. So the patients who could not get on telemedicine website, they could join on a telephone line and be converted again on the telemedicine software. So this is a roster of doctors. This is a cross-section of patients seen in different specialties. You can see COVID took the bulk of the patients. And then at the same time, we started a telemedicine certificate course to encourage doctors to take up this process with more education and more knowledge. And then the success of this particular telemedicine helpline got known to the Health Minister of Pakistan, Punjab, Professor Dr. Yasmin Rashid, and she initiated another project for elective non-emergency services, whereas the basic health unit patients can be seen by the specialist using telemedicine services. And this is where we did the field tests in small villages, and we were able to scale down the telemedicine software to 356 kilobyte upload speed, which is the speed of a 3G connection, where that means the internet may not be required. It could be just a network connection enough to do the telemedicine. So this is where we started training you can see the masks coming up now. We started training the vaccinators, the dispensers, the technicians who were at the basic health units to be able to connect the patient to the doctor. And then the doctors were sitting in the district headquarter hospitals, and they were able to see those patients through the software and give advice. So patients did not have to travel. And that was not just convenience, it was safety for the doctors and patients both. We lost about more than 100 health professionals in a short space of time. So the doctors were scared to meet the patients in this time as well. And then this is a story of success. And as you can see, that Sehat Ghar alone has so many specialties involved. Then this project went into ICU. We started doing a ward round of the ICUs. The consultants based in the UK, Pakistani consultants, they started doing telemedicine rounds on the specialized software. And BBC again published a report on that particular software that doctors living abroad can help countries, patients in other countries through specialized telemedicine software. So I'm glad to report today to the audience that Pakistan has more or less led in one form or another telemedicine services in the region, uh, not just doing video audio calls, but actually doing clinical telemedicine, which is what I support. And I support a culture of telemedicine rather than the product. We have taken a start from the product. We went through a service, and now in Pakistan, we are touching the culture of telemedicine, which is where the success will really emerge from.